We'll now turn to Mr. Nichols, the Director of Health Policy at the New America Foundation. Welcome, Dr. Nichols. Good to have you here. Thanks so much for your patience. Dr. Collins as well. Thank you for your patience.
Thank you, Mr. Chairman, Senator Wyden, and other members of the committee. I'd like to thank you for inviting me to testify on health system reform today. Your invitation asked me to address three specific questions. The first of which is, how should the committee evaluate healthcare reform proposals? I would offer two criteria for your consideration. First, does the proposal match the scale of our problems? And the second, is the proposal capable of earning bipartisan support? Now, your own charge at the beginning of this hearing, Peter Orszag last week, I have some charts in my written testimony. They all make the point. You all clearly get it. The scale of our problems is very large, so I won't belabor that point. I'll just say, to match this scale, what I will call a major league proposal worthy of your time must have three elements. It must cover everyone. It must have some way to reduce cost growth in the long run and increase value. And it must offer a credible financing package that can sustain the system over time. Any proposal without these three elements, in my view, should be labeled minor league and kept at the end of your queue. If the proposal would not cover everyone, it's not serious, for it continues to ignore the cost shift and adverse selection that messes up our insurance markets. If it doesn't have a credible plan for reducing cost growth, you know what? None of us are going to be able to afford health care in the coming decades. Third, if the proposal does not have a credible financing package, it's not being honest with the American people about the cost and benefits of investing in a new health care system. You all know we've tried dishonesty before. I will simply observe it didn't work. We can do better than that. On the bipartisanship point, the second criterion should simply be this. It's got to be capable of earning bipartisan support. I've heard a lot of that. In fact, I've heard more of that this morning than I've heard in 5 years of testifying up here. This is a very good committee. I applaud your work. Bipartisan reform means that each side must recognize the key elements of their own priorities within the solution. For Republicans, in my mind, this means individual choice and market forces, and for Democrats, it means a solution must work for all of us, including those who are low income or high health risks. And I believe it is sharing these perspectives that's what brought Senators Wyden and Bennett to co-sponsor the Healthy Americans Act. And in my judgment, this is the only major league proposal that has bipartisan support in the 110th Congress at this moment. Now, the second question you asked was, what are some possible options for health care reform? In my view, after many years of looking at this, I'll say there are only three credible ways to cover all Americans. Single-payer Medicare for all, employer mandates plus individual mandates, or individual mandates alone. I will tell you, technically as a health economist, they all could work. They all have their pluses and minuses. But each approach really does have some weaknesses that are worth addressing. In my view, the largest weakness of the single-payer approach is that the American people do not seem to me to trust government enough to let it take over the health system altogether. On the employer mandate side, I'm really sympathetic to Senator Stabenow's problem in Michigan. The fundamental worry I have about an employer mandate is international competitiveness. And again, I have some charts in my written testimony I'd be glad to talk about, but I think it's fundamentally true. If this wasn't a problem, employers wouldn't be dropping coverage like some are, employers wouldn't be reducing the share of the premium they're paying like many are, and employers wouldn't be reducing the generosity of the coverage they offer like almost all of them are. This is not being shifted. They are bearing some of this cost. So that leaves me with individual mandates. And to my view, they have much to recommend them. First, they're consistent with the personal responsibility vision of conservative reformers. And they also make insurance markets both more efficient and more fair by solving the adverse selection problem, which liberals like on good days. The one real fear of individual mandates is precisely the one expressed by Senator Stabenow earlier. How can you make sure these packages are going to be affordable? And I submit to you that is important. That is the most important question. In a sense, I would say this is not really a critique of individual mandates per se, but a broader distrust of the whole reform system. And I submit, therefore, the burden of reassuring proof about commitment to affordability and fairness is in the details of the legislation. And here I would say the Healthy Americans Act does a better job of this than either the state of Massachusetts or Governor Schwarzenegger has done so far in their proposals. So part of why this is true is because the Healthy Americans Act can redirect the large and regressive tax expenditure money that gives federal reformers more degrees of freedom than any state has on their own. The final question the committee asked: how do we provide quality health insurance to more individuals and families, decrease the number of uninsured, improve health outcomes, and contain costs? First, I applaud your ambition. But this is the proverbial key question. I would offer a two-part overarching answer. The first is simple: buy smarter. It gets to the operational details Senator Whitehouse talked about. And the second, though, may be more important: think hard about whom we're buying for and why we're doing it. I will defer to Arnie and Sarah to follow on buying smarter. They're going to talk about that a lot. I'll just mention the three elements that have to be there, and I think we all already agree: electronic records, better incentives, and comparative effectiveness information that's widespread. We need them all. We need them tomorrow. And if we start this afternoon, we can have them all in 5 years. But I want to close by focusing on the last part of my answer to this question: for whom are we buying and why? I submit to you there are 10,000 technical questions about health reform. We've talked about a lot of them today. You're going to talk about all of them a lot of times after this. But there's one fundamental question, and I think it's a moral question, that we should ask before we begin to answer any of the technical questions. And that is, who should be allowed to sit at our health care table of plenty? This is a question about community. What kind of community do we think we want to nurture and build and maybe rebuild? The older I get, the more gray in my beard, the more convinced I am the best descriptions of community we have are the oldest descriptions we have. I'm talking about the Hebrew prophets, which, as you know, inspired Jesus and Muhammad as well. A fair reading of our Jewish, Christian, and Muslim scriptures says communities have an obligation to feed the hungry, the widow, the orphan, the stranger, who would otherwise have starved. Preventable starvation was unacceptable in ancient times, even for the stranger, because all humans were believed to be made in the image of God and believed to possess the right to participate in the life of the community. I submit to you, healthcare has become like food, a unique gift capable of restoring and sustaining lives that are stricken with illnesses, which could, after all, be any of us, anytime, because we are all the stranger. Now, the Institute of Medicine has concluded, after 3 years of committee meetings, 6 volumes of published reports, lots of footnotes, 18,000 Americans die every year for lack of health insurance, which prevents them from getting the care the rest of us routinely get. These preventable deaths and the human suffering and lost productivity of preventable illness are a dark stain on our nation. And the fact that most uninsured lack health insurance because of cost, in my view, is tantamount to denying food to the poor, the widow, and the orphan when Moses, Jesus, and Muhammad taught. I do not think they would approve. At the same time, no community was ever told to share food exactly equally, to give all its food to one person. Stewardship of the collective resources of the community was always part of leadership. Indeed, when you consider another of the Institute of Medicine's findings, that the total social cost of the uninsured, including the economic loss of premature death, unnecessarily prolonged illnesses, etc., that total social cost of the uninsured is roughly equal to the new public cost of covering the uninsured, which is why, by the way, the math of Senator Wyden's bill works out. You realize that health reform is at least as much about stewardship as it is about charity. I would also point out that in Leviticus, the source of all this, the landowner is not told to cook the food and invite the stranger home to dinner, but rather is told to leave the food in the field for the stranger to gather themselves. Our oldest obligations to each other have always been reciprocal. Each community has the right to define the rules of participation, but it must keep the door open to willing passers-by. Therefore, requiring people to obtain properly subsidized coverage and to take personal responsibility for their own health is perfectly consistent with this interpretation of the timeless moral case. As is expecting the leadership of the community, that would be you, to exercise stewardship over its collective resources, including the healthcare delivery system. This shared responsibility extends to making the system more efficient so we can buy healthcare smarter for all of us. Thank you very much.
Thank you, Dr. Nichols, for really excellent testimony. I think you framed the issues in a very clear and compelling way. Let me go to the question of comparative effectiveness. Very striking in your testimony, Dr. Collins, is the wide difference we see across regional lines in the country. Dr. Nichols, you mentioned comparative effectiveness along with electronic records and changing incentives. How do you see comparative effectiveness being employed? One of the things that I think it's pretty clear, we've got a common agreement that comparative effectiveness has to be part of the solution. In fact, in our budget, we have a reserve fund for comparative effectiveness. Dr. Nichols, how would you employ it?
You know, Mr. Chairman, I think that is the question. And I would offer the following sort of example. Let's start with something concrete, what we do now at the FDA. Right now, to get a drug approved, the company has to show that the drug is safe and effective, that it doesn't have untoward side effects, and beats a placebo. With all due respect, prayer beats a placebo. So maybe we should think a little bit about raising the bar. What if you said you have to show against existing treatments and for which subpopulation? Now that'll take longer, so you got to give them the right incentive. You got to give them a longer period of exclusivity. But the fundamental point, show us at the point of decision about whether to go forward with widespread marketing that it beats existing treatment options and for whom. Then you take that information, and what I would do, sir, is put the information in the public domain. That's why the creature that makes the information has to be, in my view, a combination public-private partnership. The research has got to be done in academic medical centers so we believe it, and the funding's got to come from the government because we're the ones producing the public good of the information.
Let me go direct you to the doctor, just interrupt you for a moment if I could. Dr. Milstein came here supporting specific legislation. Have you looked at the Greg Clinton proposal?
I think it's a step forward. I think it's a very good idea to allow analysis of the data inside the Medicare program. I'm frankly not committed to the notion that the individual physician is the right unit. I think, as Arnie talked about, there's difficulties with numbers of patients of different kinds, so that, as he put it, the density of a patient population, it may be better and smarter to aggregate over groups, and there may be different ways to do it, but as a way forward, using the data we have now is certainly a good way to, in a sense, create rough rank order of who's doing extremely well. I think the example that Senator Allard talked about of Intermountain Healthcare in Utah, Senator Wyden implied, Kaiser in Oregon, Geisinger in Pennsylvania, Mayo in Minnesota, Henry Ford in Michigan. A lot of folks are doing this right. But what we don't have, and that's the next step, we don't have a powerful system of driving the incentives through the system to make everyone do what other people know is working.
Exactly.
And that's where I would submit Medicare can play a major role in buying smarter by linking payment to outcomes. What if we said, if you're one of those docs managing the diabetics better, you get more money? Hey, what a concept. I suspect, we'll get a... So you take this information, you put it in the combination public and private buyers we have now, and they work together to drive the incentives. That's the best way to go forward rather than having one-size-fits-all.
Senator Collins, on the same question, the comparative effectiveness, how can that best be employed?
I think it's very important in terms of just from the benefit perspective too, to think of how we're structuring benefits. So once we've done the difficult work of looking at what's comparatively more effective, that our benefit designs steer people in the direction of using higher quality, higher valued services. Right now, we don't have that very much in our benefit structures. People are directed towards overusing ineffective services and underusing services that could be very effective. So the benefit design is a very important piece of thinking about comparative effectiveness.
And who should have the responsibility for that benefit design and using comparative effectiveness measures? Where should that responsibility lie? We were talking, Dr. Nichols was talking about in the context of FDA. I'm wondering about with respect to individual doctors making judgments about what treatment they're going to use for specific illnesses. The thing that's never been clear to me is how do we translate this data down to that individual doctor and incentivize them to use the best practices?
Well, it comes back to what I think Senator Whitehouse was getting at, and that is we have to have a system of information, an infrastructure, if you will, so that not only do you have the electronic record of the individual patient, but each clinician-patient encounter should have access to the best practice information that the Intermountains, et cetera, develop, so that when presented with, okay, here's this patient, this problem, here are my choices, here's the one that seems to work best for this kind of patient. You know, this decision support tool dimension of the electronic information infrastructure may be as important. That's how you're going to get the savings from the RAND study, is getting that information out there to the clinician-patient encounter, and also then paying them more when they do well, and perchance paying them less when they don't do as well.
Thank you very much. Senator Whitehouse?
Thank you. Boy, there's so many things I'd like to pick up on, but I think the first one is I'd like to emphasize what you said about the potential hazards of taking comparative effectiveness analysis and trying to drill down to individual doctors. That concept just scares me to death, because I'm so concerned that by the time you drill down to that individual doctor and you have figured out that the reason Dr. Whitehouse is showing lower costs is because he knows that he's not very good at this stuff, and he's referring all his tough cases to Dr. Nichols, who's really the local expert in this matter, as a result in the community known to be the local expert, as a result gets the toughest cases, as a result has bad outcomes. By the time you have gone down into their patient records and teased out that data, you have got such a regulatory load that this system now has to carry, and particularly run through private insurers, is so gameable that it'll make, I think, our present claims processing nightmare look like a walk in the park. So I'm really interested in trying to figure out ways to, it's vitally important that we do this. I just think drilling down that far with our present level of capacity is really problematic. My thought at this point would be to do it more regionally and hold basically regions and states accountable for their performance and pay more in certain areas than others. It's a little bit rough justice, but that really then incents the local community to sort out its own affairs and to do the kind of internal work that is necessary. And my sense, I'll ask you to react to this after I make this last point, my sense is that we are so primitive at this point in developing comparative effectiveness and in having the institutions in place to really work this issue, that we are far better off as a country if we push some of this down to the more local level, where people have existing relationships, where they trust each other, where they see each other in the market on Sundays, and where you can kind of let 1,000 flowers bloom, let the laboratories of democracy do their thing, and take more advantage of the innovation that can develop at that level. So there's a series of different thoughts, but I'd like you to comment back to me on them.
Well, all of them are good. I would say unambiguously we're not going to be successful in translating incentives to a medical marketplace unless the physician's behavior is indeed reflected in both what they get paid and the outcomes over which they have control.
Yeah.
So this notion of, that's why I'm worried about the individual physician thing as well. However, I would say it would still be useful to know which of these physicians are better, but maybe you don't want to make it public, and maybe you don't want to tie payment to that specifically, but you want to go and say, you know what, you're an outlier, what's the deal? What do they do at Intermountain? They go down the hall and talk to them. It's exactly the kind of local community conversation you're talking about. So one idea would be to say, okay, look, here's a referral network. You know, Congressional's done a lot of work on high-performance networks. Here's a de facto referral network, let's just say in Providence. Let them choose themselves to join this group over which we hold that group accountable.
Yeah.
Then they're referring to each other, then they really have a stake in it, and I would submit a control over it, and we get much more likely to get physician buy-in. The worst thing we could do, in my view, is to rush headlong into this area and turn the physicians against us.
Yeah.
I have much scar tissue from 92, 93. We are not going to reform the healthcare system if the physicians become our enemies. Just a thought.
And I think a related thought is that if you're focusing on extracting out of this information that we have the best practices that actually exist out there, and then setting them up as the model for everybody to work towards, rather than setting up a definitional thing of who's good and who's not good, you get the same place. It's far less gameable, and there are ways within the existing administrative apparatus of government, particularly state government, where you can have meaningful hearings and a sensible way of figuring out what those best evidence practices really should be.
That's extremely important, and I would submit that's the only real solution in the long run. We're going to get where we want to be when every physician wants to be as good as that practice outcome, and they're going to want to do that if we both show it to them. They need to know there's too much information, they can't possibly process it all, and secondly, to have incentives so they don't get screwed financially by pursuing the right strategy, and that's why we need both those things, absolutely, no question about it.
I appreciate your testimony.
Senator Stabenow.
Well, thank you, Mr. Chairman. Just to continue on the whole discussion on comparative effectiveness for a moment, first of all, there are terrific software packages out there now, and it would be interesting, Mr. Chairman, I think, to even show some to the committee as it relates to these issues, because there's already software out there. There's already efforts going on comparative effectiveness. That would be, I think, very interesting for us to take a look at. But to take a step back from what you were saying in terms of physicians, and when we find a situation where we have either been freezing or proposed cuts in Medicare reimbursements for physicians, then we say to them, we want you to go out and buy this hardware and this software and be able to spend all this money. And by the way, you'll get the least savings in the system. The big savings goes to the federal government and the hospital systems. And in Michigan, where we're actually, I think, one of the states really moving along aggressively in health IT, they find that it's most difficult to get the physician to come on board. The hospital system sets up health IT, but it's the cost and et cetera. And so that's one of the reasons Senator Snowe and I have been proposing that we do some simple things like accelerated depreciation on costs for physicians to be able to get equipment, payments that are not only a higher payment for quality, but a higher payment for use of technology, so that we're rewarding what we need, because we're never going to be able to compare anything until we get these folks on electronic records and get a common system. And so I keep going back to how do we get this started so that we are rewarding every provider. Medicare could easily be rewarding providers that are using these systems, and then go to comparative analysis after we get them on board. So I hope that we're going to be able to move this, to be able to do some things in that area. A different kind of question. I want to go back and actually ask Dr. Nichols, you to revisit something you went over very quickly, and I want to be the devil's advocate here today as we're all talking about individual mandates. You talked about 3 different approaches. I would agree with you on the employer mandate personally. I do not believe that's the way to go. Individual mandates, possibly, depending on how we do that. But you skipped over the first one, Medicare for all. And I'd like you just to go back and revisit. When you say the public wouldn't accept that, you know, my mother, I think, would wrestle me to the ground if I tried to take her Medicare card away. And the truth is, it is the only universal system we have. Politically, it may not be viable to go to that approach, but from a substantive standpoint, it has choice. You get basic coverage. If you want to add doctor visits or home health coverage, you sign up for Part B, you pay more. You want prescription drug coverage, sign up for Part D, you pay more. It has 2% administrative cost, much less than the 15 to 20% in the private sector. And I guess I would just like you to, I'm not so sure it's the public that wouldn't accept it. I think politically, because of all the interests, it would be difficult to pass. But the public, I think, thinks Medicare works pretty well. So I wonder if you might just speak a little bit more to substantively the Medicare.
I think it's an excellent point, and I would say, I'm basing my observation about the public on the speaking that I do around the country. I'm very lucky. I get to talk all over the country, and I would say between Philadelphia and San Francisco, people are nervous about having one-size-fits-all for them. They think Medicare works great for mom, and they're looking forward to getting there, okay? That's correct. It's a safe thing, and it works, and it's the most popular program probably our country's ever had. But that does not mean they're willing to accept a government control over what their choices are.
So does it
compared to their...
I would just stop you there.
So they're worried about it.
Yeah.
That's all I'm saying. And I would submit the bill that's in, I believe, the House now, I believe it's Representative Starks, it's basically Medicare as is for all, which allows the private plans to compete. I think that's the way to go if we're going to go that way. And I think that would preserve the choice. Go back to what is our fundamental problem, Senator? I would submit it's lack of information, which leads to a lack of trust. The reason we had the backlash against managed care was not that some managed care plans weren't outstanding in quality. Some in your own state,
Right.
But they couldn't convince the people that they were better, and they thought employers were forcing them into them, and they didn't trust them. And some of them, of course, did behave badly, no question about that. But the point is, they didn't have information to convince them of high quality. So choice became a proxy, a protection, a safety valve. And that's why I think choice is so important. So if you had choice in the Medicare for All, then I think that would be something that would be more talkable. But I would also submit, look at, and Peter Orszag's testimony last week made it clear again, over time, the rate of cost growth in the Medicare program basically is the same rate of cost growth as the private sector. It's done no better and no worse. Now, this is no shock to people like Sarah who understand the system. It's all one system. Of course, this is true. But the point is, we haven't done better at buying as a very concentrated single buyer than the multifarious private sector did as well. Why is that? I submit the reason, you come with me to Senate Finance and I'll show you the reason. Okay? It's because basically the Medicare program, which is an insurance program for our most vulnerable people, is also, unfortunately, in real life, an income support program for mediocre providers. Democracy will not let us be as sort of demanding as we would like to be. So I think the cost control potential and the concern about choice is real. What I believe, Senator, is if we set up a system where we had one big marketplace and there was a lot of competition for it, then that system could work in lots of different ways. It could evolve in lots of different ways. We share the same goal.
Well, and just a final comment, Mr. Chairman, and that is one, in asking that question, I was assuming that there would be that private choice in Medicare. Going back to my mother, she's actually in an HMO and loves it. So that's not what I was assuming. But I would also say, just as an editorial comment, that we also, in the Medicare prescription drug piece, I believe have higher rates because negotiation is prohibited. So, but nonetheless, I would just say, before we dismiss, I mean, I understand all the realities of going with the third choice you looked at, but I do think it's just important to speak about the fact that we do have a system that provides choice, that adds on based on paying more, depending on the services you want, that has worked well for the people that it covers.
Senator White.
Thank you, Mr. Chairman, and I'm sorry I didn't get to hear all of the comments from the two witnesses, because both of them are as good as it gets in American health care policy making, and we wouldn't have had a Healthy Americans Act if it hadn't been for Len Nichols, and we're very, very appreciative of that and look forward to having your counsel. And